Hello, fellow HIM 5301 students. My name is Sean Weber. I will be presenting on data quality in healthcare data warehouse environments by Lifehouser. An overview of the presentation, I will start with an introduction, then go into defining quality data, then importance of quality data, then challenges to quality data, then data quality processes, then process model and data quality to wrap up. I wanted to start with a little introduction. There are two uses of data in healthcare. There's clinical and administrative. The first example of clinical data use in healthcare is accuracy of diagnosis / clinical decision support system. A clinical decision support system is an application that analyzes data to help healthcare providers improve patient care. The second example of clinical data use in healthcare is computerized provider order entry, or CPOE. CPOE is a process in which a healthcare professional enters in a medical order or other instructions electronically. CPOEs have been known to dramatically reduce medical errors, which has been a major concern since the Institute of Medicine published To Err is Human, which stated that 44,000 to 98,000 patients die each year due to medical mishaps or never events. The third example of clinical data use in healthcare is evidence-based medicine, that's using data to ensure the best decisions are made by the provider into standardized procedures. A fourth example of clinical data in healthcare use is epidemiology, which is the study of the prevalence and progression of diseases. The other type of use of data in healthcare is administrative, that is through financial systems to track volumes, to track trends, to track relative value units, full-time equivalents, which in turn can be used to forecast for budgets. The first section in the paper that I read by Lifehouser was defining quality data. One of the biggest problems health information managers have to face is defining quality. Initially, data was considered quality if it met the three broad guidelines of precision, accurate, and timeliness. The definition, however, has changed from a concrete perspective to more of a relative definition of fitness for use. This quality data can only be defined as quality if it is appropriate for the user and the end use. An example I provided is a financial example. There's one side, scenario A, which is quality data, scenario B, which is bad data, and actually the data is the exact same. So in quality data or scenario A, they have accurate organizational data of numerous years' budget, volumes, RVUs, FTEs, and expenses for already established service. This enables a healthcare organization to accurately identify trends in volume, forecast future budgetary needs, and hold managers accountable for spending. And in scenario 2, or what I deemed bad data, they had the exact same data, which was accurate organizational data of numerous years' budget, volumes, RVUs, FTEs, and expenses for a brand new service. Although this information is accurate, timely, and precise, it fails to allow the organization to see beneficial trends in volume, which would assist in staffing and ensure accurate orders of supply were in hand to help lean out the organization. So why I deem this as bad data is if this service has never existed in the organization before, having previous year's budgets or previous year's financial history won't really help implementing a new service. What would have been a better idea or relative quality data would have been finding a like organization that has already implemented this service. So you could maybe use their data to see what their volume trends were or what their full-time equivalents were so you could adequately staff and supply for the new service being implemented. The next section was importance of quality data. Quality data in healthcare organizations is linked to better management of health plans, improved account receivable methods, and can be used to make the organization lean with supplies. Quality data can also be used to gain or maintain a competitive advantage in the market. An example of this is the hospital in Louisville, Kentucky implemented a system to track movement and preferences in the organization, which led to more effective direct mail campaigns. So not only can data be used for clinical purposes or administrative, but it can also be used to market. What they did was they ensured that they got accurate patient information so that when they sent out their mailing campaigns or their advertising, it went to the appropriate address and they didn't waste money on postage and stamps. Some consequences of bad data. At the operational level, it reduces customer satisfaction. At the tactical level, poor data leads to poor decision making. At the strategic level, bad data leads to issues of data ownership and the ability to use the data to provide a better customer experience. Bad data is also expensive. If the organization already has bad data within the organization and they can't fix it themselves, they'll have to pay to cleanse the data. And data cleansing is expected to grow from $100 million industry to $150 million industry in the next decade. So not only will it affect customers and decision making, but it's also expensive. Challenges to data quality. In order for quality data to be ensured within the organization, it must be used. The more the data is used, the more errors that will be caught within the system and corrected. Some challenges to this is structured versus unstructured data. Structured data is within the electronic health record, which is drop-down menus or pre-selected items. Unstructured data is free text, usually comes in with an order. Budgetary restrictions, especially in today's competitive environment with reimbursement the way it is, data isn't always put as a number one priority when maybe it should be. Another challenge is defining quality data. So when you do identify bad data within your system, a process to re-engineer data, you start with data investigation. First, you need to find the root cause. What is the problem with the bad data and how do we fix it? The second is data standardization. Once you fix that data, you always want to keep it in the same format. The third thing you do to re-engineer data is data consolidation. Once you have quality data, you keep it in one area so you know where to pull from, where to extract from. And the last is data survivorship, just maintaining the quality processes that you put in place that led to quality data. Some more data quality processes. Number one, identify the problem. Is the data redundant? Is it extensively audited? Is there enough data? Two, treat data as an asset. Inventory data. Assign responsibility. Establish a customer-supplier relationship with data. Three, implement more advanced systems. Identify the root causes. Then once you've identified them, revise processes to be less error-prone. Another data quality process is total data quality management, or TDQM. The first step in TDQM is define, identify data dimensions. The second is measurements, establish metrics for data. The third is analysis, determine causes for root data. And the fourth is improve, take action based on the analysis conducted above. Process model and data quality. Architected data warehouse environments include data source systems. Different organizations will use different source systems depending upon the need of their organization. Data warehouses. Goal is to produce ad hoc reports that can be used in decision making. Data marts. Data marts are subject-oriented integrated data that support decision making. End user analysis tool, a tool that enables users to extract and use information from the data warehouse. And transformation tools, other software and hardware that assists in managing the data warehouse environment. What you can apply from this article, either in your job or what I hope you take away from it, is first that data quality is relative. The end user's purpose is just as important as the content of the data. Therefore, how you use the data is more important or just as important as the accuracy of the data itself. Bad data can be expensive and have consequences for patients, so ensure that you identify it early so that you as an organization can fix it before you have to pay outsiders or contractors to come in and fix it. Data can be challenging, but with the proper processes in place, quality data can be maintained. If bad data is identified, it can be re-engineered through the 4-step re-engineering process. Adding additional technology to try and counteract bad data isn't always a viable solution. Having adequate ownership, policies, and data procedures will ensure that data can be used in meaningful ways. The reference I use is listed below. If you have any questions, please post on the forum, and I will be sure to get back to you as soon as I possibly can. And lastly, thank you for watching.